Do you have lower back pain, or are you a health professional looking for new techniques? In this video, we will explore together how to relieve lower back pain with manual therapy. We'll show you techniques step by step, from the anatomy of the Quadratus lumborum to myofascial treatments and joint mobilizations. Stay tuned to find out how to relieve lower back pain naturally and effectively. Let's start. First, we'll look at the palpatory anatomy of the Quadratus lumborum. We know that the Quadratus lumborum muscle is located in this area, originating from the iliac crest and the iliolumbar ligaments. It inserts into the 12th rib and the transverse processes of L1, L2, L3, L4. Therefore, we will first identify the bony landmarks. This way, we'll have fixed reference points. We start with the iliac crest, and we know that from here we can find approximately where the 4th lumbar vertebra is located. From here, we can count L3, L2, and L1, and we know that the Quadratus lumborum inserts into these transverse processes. Next, we take this other area where we find the 12th rib, thus narrowing our field of action. Once the iliac crest, L1, L2, L3, L4, and the 12th rib are located, we know the Quadratus lumborum is located here, with muscle fibers inserting like this. It also has fibers that insert into the ligaments and lumbar muscles in this area. Thus, we have accurately located the Quadratus lumborum, and we can palpate its muscle belly. How do we confirm a contraction of this muscle? We know that the main action of the Quadratus lumborum is to laterally tilt the spine. So we can ask the patient to lift their pelvis this way or to tilt their spine. In this way, having correctly located it, we notice how the contraction of the Quadratus lumborum occurs under our fingers. Now, let's begin the myofascial treatment for the Quadratus lumborum. Using the reference points we've identified, we can apply the pumping technique, putting our right hand on the 12th rib and our left hand on the iliac crest, like this, with a crossed grip. At this point, we position ourselves well over the muscle and apply this distraction movement, moving apart from the muscle's two insertion points. This technique is comfortable for both the patient and us who apply it. We can also incorporate a stretch by utilizing the leverage of the arms and legs. We take the leg on the same side as the Quadratus lumborum and cross it over the other, also moving the pelvis diagonally, like this, to put tension on the Quadratus lumborum. Additionally, we ask the patient to lift their arm like this, as we see. We have already put the Quadratus lumborum on stretch, and from here we reposition ourselves like this with crossed hands and do the same work of myofascial inhibition. That is, the same technique we did initially. We push down, moving our hands apart, hold for a few seconds, and then release. Then we push down and release. We can also utilize this technique, grabbing the iliac crest with our right hand. We position ourselves with the left hand on the 12th rib and use our body movement to execute the same technique, but using a different hold. Now we will review the palpatory anatomy of the diaphragm muscle to correctly apply the manual techniques. We know that the diaphragm divides the abdominal cavity from the thoracic cavity and is shaped like a dome, consisting of a dome-shaped muscular belly and a central tendon that inserts into the spine. The dome of the diaphragm attaches from the 7th to the 10th rib and into the costal cartilages. Knowing that the nipple is located approximately in the 4th or 5th intercostal space, we count down 5, 6, 7, 8, 9, and 10. And here are the corresponding costal cartilages. So down here we find the diaphragm on both this side and the other. On the left, we will locate the diaphragm's pillars, those small tendons. The right pillar inserts at T12, L1, L2, and L3, and the left pillar inserts into T12, L1, L2. This is the diaphragm structure, and we know its main job is to allow breathing. We can ask the patient to breathe in and observe how the abdomen extends and air fills the lungs. Then we have positive and negative pressure. We ask the patient to breathe out, and at this moment the diaphragm dome ascends and the abdomen tends to go back to its normal position. Knowing this, we can act on the diaphragm by utilizing its costal insertions, because from here we can see the rib cage and the xiphoid process where all the costal cartilage originates. From here we can rest on the rib cage, also doing some internal sliding without affecting the abdominal area. Next, we position ourselves correctly with our thumbs on the rib cage. We maintain our contact with the rib cage and slide a bit inward. At this stage, we ask the patient to inhale and track the expansion of the thoracic cage. As we track the inhalation, we make a small upward push and try to resist the downward movement of the costal cartilages. Next, we request another inhalation while following the movement, and at the moment of exhalation, we retain the movement. This way, we influence the diaphragm's central tendon indirectly when we hold the costal area. Another technique we can use, opposite to this, is one that stretches the diaphragm fibers, which can be applied by depressing the rib cage. To execute this step, I place myself laterally to the rib cage, raising the patient's arm to create tension in the rib cage. I stand behind the patient and rest my left hand on the rib cage. I request the patient to inhale, and this time we will hold the rib cage during exhalation. Then we follow the first exhalation, but during the patient's next exhalation, we block the rib cage. Each time the patient exhales, we lower slightly with the left hand. Then, during inhalation, we hold and let the air out. Then we carefully release and lower the patient's arm. We repeat these techniques a few times based on the clinical case. Treating the diaphragm through its pillars is quite interesting. So, how do we locate the diaphragm pillars? We know they are under the paravertebral muscles, and the only way to locate them correctly is to work on the 12th rib and try to go under the paravertebral muscles. We know the 12th rib leads to the 12th vertebra. As we go down, we encounter L1, L2, and L3, and we know that the diaphragm inserts here, so the pillars are located right beneath. We ask the patient to rest their hands on their shoulders like this. We lean on them and hold them. Then we perform a slight forward flexion, tilting the body to the other side and moving our hand from the 12th rib towards the lumbar area, pushing in an oblique and opposite direction, in an oblique and opposite way. At this moment, we rotate the patient towards our side to relax all the paravertebral muscles and make a gentle rotation, holding the patient and applying pressure with a finger towards the pillars. We repeat these small rotations to perform myofascial work on the right pillar of the diaphragm in this case. To carry out the same technique on the left side, we will ask the patient to lie on the other side of the table. This is a technique that might induce some pain, yes, but it is quite effective for lumbago. Now we will review the joint techniques for lower back pain. We will mobilize the lumbar vertebrae with the patient lying on their side, which will allow us to perform a twisting motion in the lumbar area to highlight the spinous processes and conduct detailed joint work in detail on the lumbar vertebrae. First, we take the patient's right hand, position ourselves with our right hand on the lumbar area, and perform a rotation of the upper trunk. At this point, we feel that the movement has reached the area we are palpating, and we stop. We keep our hand on the lumbar vertebrae and bend the patient's knee. We place our other hand under the patient's elbow to stabilize them with our body, and with the other hand, we check all the spinous processes. From this position, we identify the iliac crest to locate L4, and descending, we find L5 and S1. Once this position is established, we can perform this type of mobilization. We touch L1's spinous process with our middle finger, and with the other middle finger, we feel L2's spinous process. At this stage, we lean over the patient, and with the lower hand, we apply traction in this way. We can also apply another grip. This grip is easier for us. By positioning the thumb on the spinous process of L1, blocking it downwards and performing this type of movement and rotation, we can perform the same technique. One hand blocks L1 and the other pulls towards us. We always ask the patient if they experience pain. Subsequently, using the same technique, we can descend and mobilize all the lumbar vertebrae. The important part is doing this work. Thanks for watching our video on treating lower back pain with manual therapy. Don't forget to subscribe to our channel, like the video, and leave your comments below. Make sure to also watch the video on how to treat sciatica and the treatment for Piriformis syndrome. You can access them by clicking the side thumbnails. Look at the link in the description to see our courses and further develop your skills. See you in the next video.